Hello everyone. Welcome all to this Indo-Nepal panel discussion and collaborative session by White Army of India in association with Grey Medicos of Nepal. It gives me an immense privilege to host this session. Our hearty welcome to the mentors of the day, Professor Sreenivas, a renowned consultant neurologist of Andhra Pradesh, India, and Dr. Rajkumar, consultant neurologist of Nepal. Welcome to you, sir. And
Thank
yeah, I welcome our presenter of the day, Dr. Prakash, third year MS General Surgery of UCMS Nepal. And yeah, welcome to all the viewers who have joined us via YouTube and Zoom. With the permission of our mentors, we are starting our session. And over to you, Dr. Prakash.
So I would like to start now. So I'm going to present a case of a 60 years old lady who is Hindu and Butwal, Nepal, who is housewife, and we presented to our emergency department on 25th of October. On the 25th of October, and we examined her in the emergency department on the same day. And she presented in the emergency department with the chief complaint of headache for 3 months, and left upper and lower limb weakness for 2 weeks, and abnormal body movement 3 episodes for a week. In the history of presenting illness, my patient was apparently well 3 months back. Then she developed headache, which was gradually in onset. It was diffuse type, intermittent pain. It was more in the morning, and there was no aggravating or relieving factor, and was associated with vomiting, which was watery, non-bilious, and was projectile. It was then followed by weakness of the left lower limb, which was gradually in onset, slowly progressive to the left upper limb, and she could walk with support, and she had some difficulty in holding a glass of water. And then it was followed by 3 episodes of abnormal body movement during the 1 week period, with upwelling of eyes flowing from the mouth, and there was facial deviation. And in the negative history, there is no history of loss of consciousness, no transient loss of vision, altered sensorium, fever, involuntary movement, no history of loss of sensation, double vision, tinnitus, difficulty in swallowing, no history of neck stiffness, weight loss, gait disorder, nystagmus, speech disorder, no antisocial behavior, no personality changes and memory loss. There was no history of shortness of breath, cough, breast lump, and no history of trauma and radiation therapy. So in the past medical history, there is no similar illness in the past, and she is a known case of hypertension and under medication for last 10 years. She is also under medication for hypercholesterolemia for last 1 year. Intervention in the personal history, the patient consumes mixed diet, and she does not smoke and does not consume alcohol, and her bowel and bladder habit was normal. In the family history, there is no any significant family history in this patient, like history of any tumor. Or in the drug and allergic history, she has no any allergic reaction known till date, and the patient is under amlodipine 5 mg for last 10 years, and she's taking atorvastatin for 1 year. In the menstrual history, she attained menopause at 48 years. In the socioeconomic history, this is not significant in this case. Now coming to the general examination.
Yes, sir, any comment on the history, sir? Is it complete? Any comment you want to add, sir? Professor Sreenivas?
Yeah. Doctor, at the end of the history, what do you think?
At the end of the history, yes, sir. At the end of the history, I think there is some because there is weakness of the left half of the body, and there was headache and vomiting. There could be some space occupying lesion in the right side of the brain.
Okay. It is slow in onset. It started on October 25th and slowly progressed. So it has taken time. It does not present it suddenly.
Yes,
and what do you think is the cause of headache? Brain is by and large insensitive to pain. There are no pain receptors. So why will a tumor produce pain or headache?
So it's because the dura is, the meningeal layer is sensitive to pain, and especially the dura. When the dura is stretched, So it causes pain, giving us headache. So because of the space occupying lesion, that can increase the intracranial pressure. So this can lead to headache.
Very good. So brain per se has not got any pain sensitive structures. It is because of the increased ICP, the stretch of dura and dural vessels, that causes pain. That's why we see headache
Yes,
in meningitis, where the meninges are inflamed, or subarachnoid hemorrhage, again where there's chemical irritation of the meninges. So that is
Yes,
for the headache. Why it is more common in early mornings?
It's common in the morning because when we wake up from sleep, usually there is a retention of carbon dioxide. I think.
I'll put the question other way so that you'll be able to answer it better. One of
Yes,
the
sir.
easiest ways to treat raised intracranial pressure is ask him to come forward, come from the supine position, ask him to come forwards to
Yes, sir.
sitting position. So how do
Inclined
you
forward,
relate
yeah.
that with the headache?
So that
So
helps in the drainage.
when you lie down for a long time, there'll be raised
Yes, sir.
ICT. So one of the treatments for ICT is ask him to sit,
Yes,
come
sir.
forward.
So
So
that
that's why you see more in the early mornings.
yes, sir.
And second thing, doctor, you said there is seizures. So
Yes,
what
sir.
do you understand? So how do you relate this?
So seizure occurs because of any electrical impulses that occurs in the brain, and especially in the cortical. Whenever there is cortical lesion, that causes seizures. Sir.
Yeah, good. So this is basically a cortical lesion. Two things.
Yes,
One,
sir.
this lady has got seizures. Second, there are no brainstem signs. I was carefully listening to your history. There is
Yes,
no visual blurring, or there was no diplopia also, double vision.
yes,
So it
yes,
is
sir.
limited, and that too, there's only weakness. There's no sensory disturbances. Perhaps this is limited to the cortex and more so in the motor area, according to
Yes, sir.
your history.
Yes, sir.
And yeah, and then you said weakness going on for about a few weeks, gradually
Yes, sir.
progressing.
Yes, about
Suppose
2
a
weeks.
person has been gradually progressing with weeks, suddenly person deteriorates and the weakness suddenly worsens. What will you think?
So if the weakness is sudden, there can be cerebral vascular accident like hemorrhagic stroke.
Yeah, that is
That
presentation itself is sudden. But
that
suppose in your case, a person slowly progresses and suddenly becomes a dense hemiparesis, a
that
sudden
means
weakness.
the lesion is going deep through the brain, sir. Starting from the cortex, that is going deep inside
Yeah, that could be a possibility. But basically, we think of bleeding into the
towards
tumor.
the
A tumor progresses, has got weakness which progresses slowly. But then if there's sudden bleeding into the tumor, the
yes,
presentation is more of sudden onset. Weakness
sudden
becomes
onset.
sudden. And very good history you said. You said headache, seizures, weakness. So basically there are three types of presentation. One
Yes,
person has got only a local clinical signs being presented. Second, a
yes,
generalized signs like headache, seizures, and weakness.
yes,
The third could be a metastasis also. So this is a
yes,
tumor which is presented in ways of a generalized presentation with headache, seizures, and weakness. Yeah, I
yes,
think more in favor of SOL, because a slowly progressive lesion, headache, seizures, slow onset of weakness. I think more in favor of SOL. Very good history,
yes,
doctor.
yes, sir. Thank you, sir.
Sir, Rajkumar sir, you want to ask any questions?
Just what Sir is telling,
Okay.
basically from the history, our main aim is to uh,
Localize.
identify what is the type of lesion and where is the site of lesion. Okay.
Yes,
So you have just given the three main complaints. Number one is headache with vomiting. Number two, you have said about weakness and the seizure.
weakness. Yes,
Yeah,
sir.
weakness and seizure. So these three main symptoms. So you have to think about where is the site of the lesion, okay, from these three things.
Yes, sir.
So, and what is the nature of the lesion? Nature of lesion, yeah, you have rightly said, we should first think of some slowly
Space.
progressive lesion, so most probably some space of lesion. And where it is? Is it brain? Where? In the frontal lobe, in the parietal lobe, in the temporal lobe, okay? So you
Yes,
look at that way. And if it is, I mean, it is in the cortical or the deep cortical, okay? So if it is in the cortical, and again which in the which lobe. So from the history again you have to rule out. You have to take, like you have rightly taken few negative history. Okay,
Yes, sir.
so from that you have to rule out where is the site of lesion. So you have to focus on that. Number one. Number two, and coming to the again site, where it is. Is it in the maybe in the infratemporal or supratemporal? Okay,
Yes,
infratemporal
sir.
maybe brainstem. Okay, maybe in the cerebellar region.
Cerebellum.
Okay,
Yes, sir.
so we have to tell that also. So one few you have mentioned like nystagmus, ataxia. So that also you have to mention. So see whether it is supratemporal, infratemporal lesion, in the cortical also, deep cortical or in the superficial cortical. Okay. So just
Yes,
by
sir.
history, you can just make in your mind, where exactly maybe the site of the lesion. Then you go again into the examination, then to the investigation, whatever required. So I think somehow we agree that the lesion is in the cortex, okay, because there is seizure, weakness.
Yes, sir.
Okay. Then again,
Sorry.
so what do you think is the site of the lesion from this history? Can you
Mm,
specify little bit?
So from this history, as there is weakness of the left side, so there is motor area is involved. So
The right side,
this
okay, right
could
side of
be
the
in the frontal.
brain. Exactly where in the brain?
Yeah. So as there is a left-sided weakness, the right frontal region over the near the motor area, sir.
Okay, so motor areas somehow should be involved, okay, because there is weakness, left side weakness, so right motor area should be
Weakness.
involved, okay, and of course that will produce again seizure. So
Yes, sir.
that's how you can justify your, your provisional diagnosis, okay.
Doctor, if it is on the left side of the
That's
frontal
it.
cortex, what will be one of the major clinical presentations?
Yeah,
This is for, luckily for her, it is on the right side with
yeah.
left sided weakness. Suppose if it is a left side frontal lesion, other than right sided weakness, what would be the usual presentation? Can the person tell history on her own?
Dr. Prakash, do you get the question?
Yeah. Yes, sir. If the lesion would be in the left side, sir, as this is the dominant hemisphere, left hemisphere is the dominant hemisphere. So, as the function of the frontal lobe is in memory, and so there so there can be some disturbance in the memory, and the speech controlling the language related movement will be affected, sir.
Very good. Basically, they present with Broca's aphasia. They may be able to
Yes.
understand, but they can't speak out.
Yes, they can
So
speak out.
very difficult to get history from the person, from the patient. You have to get
Yes.
history from the attendants. So luckily for her, it is on the left side. So her speech is straight.
Yes.
Yeah.
Right. Yes, sir. Right sided
Right
mass.
cortical lesion, left hemiparesis.
Yes, sir.
There are no visual disturbances. There is no double vision. So what does that indicate?
So double vision meaning diplopia, and involvement of the subcranial nerve uh, will be there.
One of the common tumors which we see in practice is pituitary tumors, pituitary adenomas. They can go and compress the optic chiasma. So they usually present with bitemporal
Optic eyes.
hemianopia.
Yes.
Bitemporal hemianopia, wherein for one of the classic MCQs they would ask in a super specialty entrance exam is that a person walking on the road is not able to see the car coming with two headlights, and he may go and hit the car. So what is your diagnosis? The diagnosis, since he is not able to see the two headlights which are on his temporal side, it indicates it is bitemporal hemianopia, suggestive of pituitary lesion. With just good clinical history, we can even make the diagnosis. And as you rightly said, third, fourth,
Yes.
sixth nerves are concerned with double vision. If there's double vision on looking at far off objects, that means sixth nerve palsy. Sixth nerve is responsible for abduction. So if there's sixth nerve palsy, they can't look far off objects. Double vision on looking at far off objects. If there's a third nerve palsy adduction, so they'll have double vision on looking at near objects. So the moment you said there's no double vision, that means 3, 4, 6 are ruled out, and second nerve is also normal. So it is more like supratentorial according to your history.
Yes. Yes, sir. Can I continue?
Yeah, is gender very important in when you present a case of brain tumors? SOS. You said she's a woman. Is it important?
Yes, so in case of
yeah.
Yes, so in women, because there can be metastasis, can be there, sir, from the breast carcinoma. One is the gender, the importance of gender is that, sir. And the other is like in space occupying lesions like meningioma. This is more commonly found in female, and there is also relation of estrogen and progesterone receptors. So I think because of this, it is likely common in women, sir, to develop a brain tumor.
Yeah. Good. Meningiomas are common in women. Yeah, good.
Yes.
Okay, so basically you should cover everything, most of the things, you know, you whatever your the clinical presentation maybe, you have to dig out few history because you don't know what is the location of the tumor, you know. Like Sarah said, maybe it could be
Yes,
cellular tumor, you know, like pituitary tumor. So you ask about all the visual problems, not only visual, maybe endocrinal function also, okay, sometimes. Okay, so sometimes about the galactosemia, you know,
yes,
menstrual disturbances. So this endocrinal uh, uh, symptom will also you should ask. Okay, patient may not tell you, but simply by examination and by history also you dig out those things, those dysfunction also from the only from the history also. Okay.
Okay, sir.
Anything, sir, in the history?
I think yeah, is covered well, sir.
Okay.
So can I continue to examination?
Suppose there's a breast enlargement in a woman, suppose are suspected to be having tumor, or
Yes,
or problems with their digits, they're really grown in length, or a person becomes irritable. What are all the possibilities, doctor? Sir has already given a clue, so I have picked up from what sir has just said.
So that can be endocrinal tumor.
Good. Prolactinoma, so there could be breast enlargement,
yes.
Finger enlargement, it could be growth hormone, or Cushing syndrome.
Cushing syndrome.
They get stressed out. Yeah. Yes, doctor. Okay.
Thank you. In the general examination, patient was conscious and well oriented to time, place, and person, and was cooperative. And she was lying in her bed, and her BMI was 26 kg per meter square. So patient was not pale. There was no icterus, no palpable lymph node, no clubbing, edema, or any signs of dehydration. On the vitals, her pulse rate was 82 beats per minute, and it was normal in rate and rhythm, normal volume and character. There was no radial delay or radiofemoral delay. Blood pressure was 120 by 60 millimeter of mercury. It was taken on the right arm, and the respiratory rate was 18 cycles per minute. And her temperature was 98.6 degree Fahrenheit, and saturation was maintained without oxygen in the room here.
Doctor, you mentioned the thoraco-abdominal. What is that? Can you just go back to the previous slide before I forget?
Yes, yes, sir. So basically, sir, in the female, the respiratory pattern is thoraco-abdominal, whereas in the males, there is abdominal thoracic pattern.
Why is it so? Why is it so?
So because of the muscles, I think
the respiratory pattern breathing depends on two groups of muscles. One, intercostal muscles. Second is the diaphragm. So women, they rely more on intercostal muscles. So it becomes a thoraco-abdominal type of breathing. whereas men rely more on diaphragm. So it becomes an abdominothoracic type of breathing. So any disease which affects the movement of diaphragm, like pleurisy, like peritonitis, they shift to respiratory pattern, intercostal muscles, and it becomes thoracic type of breathing. And any disease which affects the movement of intercostal muscles, like pleurisy, they'll shift over to the diaphragm and it become an abdominal type of breathing. By just looking at the type of breathing, you can say whether it is predominantly intercostal or diaphragm, and whether it is respiratory system which is affected or abdominal system which is affected. So this is thoraco-abdominal, normal for a woman. Yeah. Carry on, doctor.
Okay, so thank you, sir. Yes. So in the high mental function, she is a right-handed individual, and she was conscious, and her Glasgow Coma scale was 15 by 15, 4v5 M6, and her appearance and behavior was appropriate, and memory was intact, and calculation was normal, and speech was normal, fluency was there, and comprehension was normal, and patient is able to read and write. On the cranial nerves, the 12 cranial nerves were examined and were found to be intact, normal. In the motor system, the bulk of the muscles were normal, and tone were also found to be normal. And power in the upper left limb was 4 by 5, and lower limb was lower left limb was 4 by 5, and whereas in the right upper and lower limb it was 5 by 5. This is according to MRC grading. In the reflexes, superficial reflexes like plantar reflex, Babinski sign was present, and superficial reflex, abdominal reflex was absent, whereas the deep reflexes like biceps, triceps, and knee and ankle reflex were brisk. In the sensory system, cortical sensation, 2-point discrimination, tactile localization, stereognosis, graphophasia, these are normal, and there was no parietal neglect. In the spinal cord sensation, there was basically two tests. We test the two column. The dorsal column, which takes the vibration and proprioception, it was normal, and the lateral column, which carries the pain and temperature and crude touch, these were also found to be normal in this case. So with this history and clinical examination, my provisional diagnosis would be right-sided space-occupying lesion with compression at the motor area, mostly likely in the frontal lobe, with features of raised ICP with seizure disorder. Sir.
Very good. You said the lesion is in the frontal lobe with seizure disorder. If the frontal lobe gets affected, what will be the clinical presentation of the seizure, the clinical type of seizure? What will be the movement of the eyes?
So it can, be a generalized tonic type of seizure, sir.
Okay. For frontal lobe, there's a specific seizure type. In fact, by just looking at the patient, you can say it's a frontal lobe seizure. What we call it as a versive seizure. The frontal lobe has got a frontal eye fields area number 8. From the frontal lobe, frontal eye fields area number 8, the saccadic pathway descends at the level of the midbrain and pons, crosses over to the opposite side and goes to the PPRF, paramedian pontine reticular formation. It connects the lateral rectus on the same side and through MLF, medial longital fasciculus, the medial rectus on the opposite side. So if one frontal area is stimulated, the frontal eye fields area number 8 is stimulated, the saccadic pathway is stimulated, and eyes will be pushed to the opposite side. So seizure is a stimulated condition. It stimulates the region. Unlike an infarct or any other disease where the frontal lobe is affected, here, it more or less it stimulates. So what happens? It stimulates. So eyes, the saccadic pathway is stimulated, and eyes is pushed to the opposite side. So eyes will go to the opposite side. Suppose if the right frontal cortex is stimulated, the eyes will go to the opposite side. And since the corticospinal tract is also affected, they'll have left hemiparesis. And one very interesting point is that all the cranial nerves have got bilateral innervation. Therefore, none of the cranial nerves usually get involved if it is a lesion above midbrains, except seventh cranial nerve, because seventh cranial nerve has got upper part and the lower part. Upper
Yes,
part is bilaterally innervated, whereas lower part gets supplied from the opposite side.
opposite
So
side.
all cranial nerves are bilaterally innervated, and most of the predominant is supplied from the opposite side. One exception to this rule is the sternocleidomastoid. Sternocleidomastoid gets supply from predominant ipsilateral side. For example, if the right frontal cortex is affected, it is the same side, right sternocleidomastoid, which gets affected. So what happens if the right sternocleidomastoid gets affected? Person cannot turn the head to the opposite side. This sternocleidomastoid will overact and will turn the head towards the opposite side. So if you see a frontal lobe infarct, in here you're talking about seizures, versive seizures. So it stimulates and therefore eyes are turned, pushed to the opposite side. If it is an infarct, on the other hand, the frontal eye field area gets depressed. So they cannot move the eyes to the opposite side. Eyes will move to the same side as that of the lesion. The sternocleidomastoid on the same side is affected. So opposite sternocleidomastoid will overact. So head and eyes will be turned to the same side of the lesion, and they'll have hemiplegia on the opposite side if it's an infarct. But here, seizures, it stimulates. So it stimulates the frontal eye fields area number 8, and the eyes are pushed to the opposite side. So you can see the eyes going to the opposite side. And then if you see such kind of eye turning, you know it is a versive seizure arising from the frontal eye fields area number 8. It gives an additional clue to you that it is arising from the frontal lobes, especially frontal eye fields area number 8.
Yes, sir. Thank you, sir.
Okay, anything you have, I think, in your examination, Dr. Prakash?
Yes, sir.
Yeah, you have covered, but your by heading wise, you know, there are a few things you have missed in the CNS examination. Okay, so you have just
Okay, sir.
you have you have done the higher mental function, you have done the motor function and sensory function. What about other things? You know, you have to in CNS examination you have to cover other things also, like you have to check the signs of meningeal irritation. Okay, maybe not for this case, but you know, when you are doing the CNS examination, it is not complete without doing other examination also. Like you have to check the gait, you have to check the this signs of meningeal irritation. Okay, about cerebellar signs, you have to say that also in your
Yes,
history,
sir.
in
Yes,
your
yes.
examination. Okay, you have to check because you don't know. Maybe sometimes you know you may miss that tumor maybe in the cerebellar posterior fossa lesion. So cerebellar signs should be checked. Okay.
Okay, sir.
And one more thing, frontal lobe, especially if the medial part of the frontal lobe gets affected, as Sir was rightly pointing out, it can cause gait disturbances. You have the leg area in the medial part of the frontal lobe. So when it gets affected, they'll have gait apraxia.
Yes.
They'll have problems with the movement of the lower limbs because you have the leg area there. So on the bed, if you're asked them to demonstrate the movements of the legs, they can do it. But in reality, when you ask them to walk on the floor, they can't. They seem to get stuck. Sometimes they say it is apraxia of gait or magnetic gait. And second thing, since the leg area is there, most of the time it is the lower limbs which get more involved than the upper limbs. And they can have urinary problems. In fact, what we say is NPH, a related disorder, normal pressure hydrocephalus, where the frontal horns of the lateral ventricle get dilated and impinges on the medial part of the frontal lobe. We have the characteristic triad, gait apraxia, where they can perform on bed, but with real lifetime movement, they can't move it, their limbs. So magnetic gait or gait apraxia, they can have bladder disturbances. Most of the time, it is the lower limb which gets affected more than the upper limb. And doctor, you said there is a weakness on the left upper limb and lower limb. Which is more involved? Are both involved in the same with the same intensity, or lower limb is more involved than the upper limb?
So it was same, sir. It was
Is
actually
that
a,
important?
yes, it was actually started from the left lower limb, then it was then followed by the left upper limb. However, the power were 4/5 in both upper and lower limbs.
Yeah, very good. If the lower limb is weaker than the upper limb, it is in the distribution of anterior cerebral artery, the frontal lobe. Whereas if the upper limb is more involved than the lower limb, it is in the distribution of the middle cerebral artery, the lateral part of the frontal lobe. If both are equally affected, what we call as dense hemiplegia, both left upper limb and left lower limb are equally affected, it is more in favor of internal capsule because the fibers are so close together that both the upper limb and the lower limb get equally affected.
Yes.
Yeah, usually in the stroke, you know, in internal capsule stroke, we usually see that, right, sir?
Yes, sir.
Okay, anything more in the examination?
As sir was telling, you need to complete it. You should talk about the signs of meningeal irritation for the completeness of a CNS case presentation. Meningeal signs of meningeal irritation, cerebellar signs. You should always make a comment on skull and spine and skin also. Why is it important?
So because to rule out infection of the CNS system, like meningitis.
We always make a comment on the skin because you have the neurocutaneous disorders. You can have neurofibromatosis or any other conditions. The skin is sometimes involved along with the brain. Why are they both involved? Why should skin get involved along with the brain? What is the mechanism? Especially when you're talking in terms of neurocutaneous disorders. We always say neurocutaneous markers, especially in tumors, you should mention about the skin. Why is it involved commonly, skin? Because skin and brain both originate from ectoderm. So when there's a problem, ectoderm gives rise to both brain and skin. So when there's a problem with the ectoderm, along with the brain, the skin also gets affected. So that's what we call it as a neurocutaneous symptoms, neurocutaneous manifestations and neurocutaneous syndromes. And second thing, why do we comment always on the skull, spine, and foot, especially the spine and foot? A long-standing disease, you need to comment. Especially long-standing diseases like hereditary neuropathies, long-standing disease like Friedreich's ataxia or anything, you always comment on the spine and the foot. Why? Because a long-standing disorder like hereditary neuropathy will cause weakness of the paravertebral muscles in an unequal way. This is called unequal paravertebral muscles. They'll have kyphoscoliosis. Likewise, it causes unequal foot muscles. So they'll have high arched foot. So when you see high arched foot or kyphoscoliosis, it indicates a long-standing process, especially the hereditary neuropathies. And skull, we always comment because one hydrocephalus, there could be obstruction to the CSF outflow, or it could be a tumor, anything which can increase the size of the skull. So we should always comment about the skull, spine, and foot for sake of completion. It may not be relevant to this particular patient, but for the sake of completion, you should mention all these things.
Okay. Dr. Prakash, you know any neurocutaneous disorder? What Sir was telling? Like you have to see the examine the skin, you know?
Neurofibrosis.
Yeah. Yes, yes.
So it's a neurofibromatosis. Neurofibromatosis.
So what things you look at the neurofibromatosis in the skin? What lesion you get?
So we get dermatitis, nodules basically.
Some macular lesion, some cafe spot, you know, some hypopigmented lesion. Okay. So if you see a hypopigmented lesion in the skin, you know, and patient has some, let's say, what sort of tumor patient will have in the brain? Or you will suspect?
Secondaries.
Because these brain tumors, sometimes they are associated with this neurocutaneous syndrome, you know?
Yes, sir.
So let's say a patient has a skin lesion with some hearing loss. What do you suspect?
Skin.
Schwannoma, you know, schwannoma.
Yes.
So you can otherwise you can first look at the skin, you know, on the examination. You may miss, you know, if you don't do examination of skin. So if you saw some capillary or some hyperpigmented lesion, you know, few millimeters size in the skin, then you think that maybe the patient with some hearing loss, you think that patient may have schwannoma. Okay, so some the diagnosis. Okay, sometimes it is given in the clinical vignette. Okay.
Okay, sir.
The schwannomas, they usually present with hearing loss, as sir has said. But why usually they don't present with imbalance? It affects both the components, right? Vestibular and cochlear component. But we see most of the time, as sir was suggesting, hearing loss. But why not imbalance?
So imbalance, so balance is also controlled by cerebellum balance. Cerebellum helps.
Balance is basically done by three systems. If at least two systems are functioning well, person is able to balance. What are the three systems which are responsible for balance, Dr. Prakash?
So one is cerebellum, sir, that helps to maintain the gait.
Vestibulocerebellum,
Yes.
yeah, correct.
Yes, sir.
Second. Doctor, the three systems which are responsible for balance are
yes, sir.
vision,
We
very
should
good, ocular.
also, the visual system should be there, sir. And there
Doctor,
should be
there are three systems.
Yes, sir.
Very good. The three systems which are responsible for good balance are ocular,
vestibular system, sir. Yes,
cerebellum, and posterior column.
Yes.
If three systems are functioning well, patient will have absolutely fantastic balance. But at least if two systems are functioning well, still is able to balance. But if more than two systems get affected, then only he loses balance. This goes by a principle, and therefore we use this as a Romberg sign. In Romberg sign, what happens? The posterior column is affected, but still the other two systems are functioning well. The ocular system is functioning well, vestibulocerebellar system is functioning well. So still they are able to balance, even if posterior column is affected. The position joint vibration, the proprioception is affected. But we ask them to close the eyes. When we close the eyes normally, other than sleep, many reflex. When someone splashes or some threatening impulse comes, we immediately close. So we ask them to splash eyes or deliberately ask them to close the eyes. And then when you remove the visual cues also, the second system also, then they will fall. So posterior column examination is removing the second system also, vision, so will have a tendency to fall. And coming to this question, why acoustic neuromas or schwannomas, they do not present with imbalance, though they present with hearing loss? They should present, no? It affects the eighth, but why don't they present? Because it's a tumor. It's a long-standing process. It is not sudden. It is not like Wallenberg syndrome, pica involvement or vertebral artery involvement, where there's sudden involvement and then sudden imbalance. It's a long-standing process. Whenever a long-standing process affects a balance system, brain tries to compensate. So compensatory mechanisms occur. Since it's a long-standing process, the compensatory mechanisms have already occurred. So they generally usually don't present with imbalance. They present with hearing loss because it's a long-standing process. That's the point.
Okay, sir. Thank you.
Okay, Prakash, now what is your provisional diagnosis? Can you read it again?
Sorry, sir. I can't hear you.
Your diagnosis, your provisional diagnosis, where do you think is the site of lesion? What type of lesion it is?
So with this history, so the site of lesion in the right side of the frontal area in the motor region.
Mm-hmm.
And the etiology can be, since it is gradual in onset, so it can be an space occupying lesion.
Okay. Okay. So with, your diagnosis, okay, it seems complete because your diagnosis requires three things. One is site. Site you have mentioned around the frontal lobe in the right side involving the motor area. Okay. And your nature of lesion is some space occupying lesion, whether it is which type of tumor, you don't have to mention. And another thing is the diagnosis, you have to write the pathophysiology, what's going on in the patient. You can mention the left-sided hemiparesis also, okay, in this UMN type of hemiparesis also in this diagnosis. And then it will complete, I think, with seizure, okay.
Yes, sir.
Why there is, you have written features of raised ICP. What were the features of raised ICP in this case?
So in this case, there was a headache and the vomiting was the features of raised ICP.
What kind of vomiting is usually seen in space occupying lesions, Prakash, doctor?
So it is projectile vomiting. type of vomiting, sir.
Very good. Projectile. What do you mean by projectile vomiting?
So without the aura, that is without nausea, if the vomiting occurs suddenly without nausea, so that is the projectile.
Very good. Generally, when we feel like vomiting, we have nausea. We feel like vomiting, nausea, and then we vomit. Whereas persons with the SOL, it goes and stimulates the vestibular nucleus directly, the CTS zone, everything. So they immediately vomit out without the preceding nausea. A vomiting without preceding nausea, you call it as projectile vomiting, very much suggestive of a raised ICT, especially SOL. Correct.
Raised ICT. Yes, sir.
What is Cushing's triad?
So Cushing triad, it is seen in chronic arrest in intraocular pressure, sir. So it is bradycardia, hypotension, and apnea, sir.
Very good. This is a tumor in the frontal lobe. Okay, it is slowly progressing, doctor. It is going slowly progressing from the frontal lobe. It is going to the midbrain, then perhaps pons, and going to the medulla oblongata. As it is slowly progressing, descending down, what are the various respiratory patterns you can observe? By seeing the evolving respiratory patterns, you can see the descent of the tumor and place the lesion exactly. So what are the different types of respiratory patterns according to the site of progression?
Giant stroke.
Good.
Like giant stroke respiration, sir. Others. So I think so. One is
the chain Stokes respiration. If it is in the lobes, you have chain Stokes respiration, waxing, waning, waxing, waning. Suddenly they respire, suddenly they don't breathe, and they start respiring. So waxing and waning type of breathing is known as chain Stokes breathing. You see it in a lobar level, a cortex level. Once it comes to midbrain, it becomes central neurogenic hyperventilation. They start hyperventilating. Like that they ventilate. But once it comes to the pons, it becomes apneustic breathing. They take a deep inspiration, pause, and then expire. Deep inspiration, pause, and expire. This is known as apneustic breathing. And once it comes to medulla oblongata, it becomes totally chaotic, irregular respiration, what you call it as Poyot's breathing. So by just looking at the respiratory pattern, you can see if there's any descent. It could be herniation or hematoma or any tumor descent. So cortex, it is chain Stokes respiration. Midbrain, it is central neurogenic hyperventilation, pons, apneustic breathing, and medulla oblongata, it is Biot's breathing. You said GCS, fine, great. But suppose you have to place the lesion, very important, where is the lesion? Suppose the lesion is above the red nucleus, or it is between the red nucleus or vestibular nucleus. By looking at the posture, how will you place the lesion? You want to know whether the person is really deteriorating, in for trouble or not, or okay, the program is slightly better. By looking at the posture.
So,
you know that decorticate rigidity and decerebrate rigidity. Any thoughts about that, doctor?
Yes, sir. Cerebral posturing, meaning that brainstem damage is there, decerebrate, and that the damage is below the level of the red nucleus.
Okay. The vestibular, the vestibular nucleus and the vestibulospinal tract is responsible for extension posture, and the red nucleus and this going to the spinal cord, the reticulospinal tract is responsible for flexion posture. So if there's a lesion above the red nucleus, that means the rubrospinal tract is intact, so person will go for flexion, decorticated, flexion of the upper limbs and the extension of the lower limbs. But if the lesion is between the red nucleus and the vestibular nucleus, if it is cut off, vestibulospinal tract now will be intact, but the rubrospinal tract is affected. So vestibulospinal tract is responsible for extension postures. So they'll go for the decerebrate posture. So decerebrate posture has got a very bad prognosis. It indicates that the lesion is between the red nucleus and vestibular nucleus. And if the lesion is below vestibular nucleus, completely flaccid. So decorticate rigidity, flexion of the upper limbs, extension of the lower limbs, the lesion is above red nucleus. So the rubrospinal tract is intact. If it is decerebrate rigidity, the lesion is between the red nucleus and vestibular nucleus. So vestibular spinal tract now will overtake and there will be extension posture, decerebrate. So it carries a poor prognosis. But fortunately for this patient, I think the GCS is good. That's what you said. And posture, I presume it to be normal.
Yes,
GCS is good. It is still confined to one side. It's not gone and affected the other cortex. How do you clinically say that it is confined only to the one side of the cortex, it is not gone to the other side of the cortex? A tumor may start expanding
because
and growing
one
affecting the other part of the cortex also. Clinically, how do you say that?
So because only one half of the body is involved.
Very good. Only one side of the body is involved. So it is confined to one side of the cortex. Second.
One side of the body.
Any other point, doctor? You said person is very much conscious.
Conscious, yes.
Yeah, the consciousness is because of the RAS, reticular activating system, coming from the brainstem thalamus going to both the cortices. So the person will have consciousness as long as the RAS system is intact. That means the brainstem should be intact or both the cortices should be intact. As long as both cortices are intact, person will have consciousness. Okay. So a person has to lose consciousness. Either both the cortices should get affected or the brainstem should get affected. That's why in pontine hemorrhage, a brainstem gets affected, person loses consciousness. Or hypoglycemia, it affects the RA system in a diffuse manner, person loses consciousness. But a big tumor on one side does not make a person to lose consciousness. Or a big MCA infarct also, person does not lose consciousness because it is confined to the one cortex, but the other cortex in the RA system is intact. So unless both the cortices get affected, person does not lose consciousness. So big brain tumor, big MCA infarct, person does not lose consciousness unless it goes and infiltrates the other cortex. So with your history, I can tell the person it is confined to one side of the cortex because person has not lost consciousness. It has not got an impinged the RA system on the opposite side. We see a lot of MCA strokes. They don't lose consciousness unless there's massive edema with midline shift. But a simple brainstem lesion like pontine hemorrhage, they lose consciousness. Simple hypoglycemia, they lose consciousness because it affects the RA system functionally. They affect structurally. Hypoglycemia, hyponatremia, or hypoxemia will affect the RA system in a functional manner. So they lose consciousness. So here the person is conscious. So it is confined to one cortex. So much of information can be derived by just clinical examination. We don't need even CT or MRI. See how much information. We said it is a frontal lobe. We said it's confined to one side of the cortex. It is not gone to the brainstem. It is supratentorial. We just do the history and examination. We're not even gone to imaging.
Yes, sir.
What I want to stress is that history and examination becomes pivotal, very, very important, especially in neurology.
Yes.
So you have done any imaging, doctor? You have proceeded further?
Yeah, I think you have.
Yes, sir, I do. So here in the image, so in the right hand side, you can see. So here is you got hypodense lesion, and in the right side of the hemisphere, and this is likely the edema. Because of the edema, this is the CT scan of head axial section. This is plain CT. So in the left, this slide shows. So this is the image, which is CT scan after the contrast is given to the patient, and you can see just above the hypotenuse there is a homogeneously enhanced lesion, suggestive of that this is space occupied lesion because the mass is taking the contrast. So this is likely tumor. So Is it okay, sir?
Doctor, you said you have very nicely said it is a contrast enhancing lesion. Please tell me
Yes,
the
sir.
mechanism why a contrast should enhance the lesions, tumor lesions.
So because these tumors are vascularized, sir. They are richly vascular, sir. So whenever we give the contrast, so they take the contrast and just thus they are enhanced.
Here you need to know very important concept, the blood-brain barrier. It is a very protective mechanism. If not for blood-brain barrier, whatever toxins are there in the blood, it will go directly to the brain and cause toxic encephalopathy. So nature and God has given a wonderful protection to the brain in form of the tight blood-brain barrier. Anything in the blood cannot enter into the brain easily. We have tight endothelial junctions, not allowing the substances in the blood to enter into the brain. Tight endothelial junctions, and therefore, generally, when we give contrast, the brain does not enhance, except for some regions, circumventricular organs, what we call it. We see it near the CTZ zone also. That's why when we give chemotherapeutic drugs for brain tumor, you give chemotherapeutic drugs. They a lot of time they cause nausea and vomiting. Why do they cause nausea and vomiting, especially the chemotherapy, the drugs you use? Because the chemoreceptor trigger zone, the periventricular organs, what we call circumventricular organs, what you call it, they lack blood-brain barrier. So the drug, what you give, the chemotherapeutic agent, what you give, it goes directly from the blood and goes and stimulates the CTZ zone. And therefore, they are predisposed to nausea and vomiting. Except for these circumventricular organs like CTZ, most of the brain, by and large, have got a very tight blood-brain barrier, tight endothelial junctions. They do not allow anything in the blood to go enter into the brain easily. But in conditions like brain tumor, or as a neurologist, neuro infections like neurocysticercosis or tuberculoma, there's a breach of the blood-brain barrier. The tight endothelial junctions give away. So normally there are tight endothelial junctions, it will not allow the contrast to enter into the brain. But in infections and tumors, the endothelial junctions will give away the tight endothelial junctions. So anything in the blood will enter into the brain. So we take this as an advantage, we give contrast. Generally, contrast does not enter the brain because of tight endothelial junctions, blood-brain barrier. But once the blood-brain barrier is given away like tumors, the contrast comes from the blood, enters into the brain, and the tumor becomes enhanced, what we call as contrast enhancing lesions. So once you see contrast enhancing lesions, it indicates that there's a breach of the blood-brain barrier. Blood-brain barrier broken down. It could be tumor, it could be infections like neurocysticercosis or tuberculoma. So contrast enhancing lesion, very rightly said, so more in favor of tumor. That means it indicates that there's a breach of blood-brain barrier.
Yes, sir.
Okay, Prakash, then what is it then?
So since this is a homogeneous, mostly this is contrast enhanced mass, and it is in the frontal region, and this is very near to the falx, and where also there is a site of superior sagittal sinus. So this can be meningioma near the, which is parallel to the superior sagittal sinus. So this is likely parasagittal meningioma.
Okay, maybe meningioma, okay, but
Or most common is the most common brain tumor is the glioma. So this could be glial
is this glioma?
cells, but this is not glioma, sir.
Is well circumscribed.
Which is well circumscribed and it is enhanced.
Could it be an infective lesion, Prakash?
Yes, sir. It would be infective lesion. If there would be ring enhancing lesions. Usually in the abscess, like we have ring enhancing lesion, and also this can be
any other lesion?
Can be neurocysticercosis, but this is less likely.
Neurocysticercosis doesn't look like this. It's a
yeah, it's calcified. Sir.
Any other common, Common infection?
Can be brain abscess.
Can it be tuberculoma?
Mm,
You see, tuberculosis present in different ways, tubercular abscess, tuberculoma, okay, or maybe tubercular meningitis, okay, in different patterns they're present. But could it be tuberculoma? You see, there's again, like a tuberculoma, well, enhanced lesion with some edema. Why not tuberculoma? And tuberculosis is very common.
yes, sir.
One difference
Tuberculosis.
diagnosis you should keep in mind, okay?
Okay, sir.
We only focus on tumor, maybe tuberculoma, why not? Just radiologically, radiological picture of tuberculoma. Okay.
Yes, sir. Yes, sir.
Any other differential diagnosis?
Mm, with this lesion, sir.
Mhm. Just forget about history and examination, okay? Just radiological picture.
Mm,
Single lesion, solitary lesion with enhanced edema, And what was the age of this patient?
she was 60 years.
What do you think? What is the most common tumor, brain tumor?
Most common brain tumor is glioma, sir.
Most common brain tumor, not
Secondaries.
brain tumor.
Overall, it is secondary. Secondaries is the most common.
Can it be secondary? The
So it cannot be secondary because it is solitary. So usually in the secondary, there are multiple lesions are seen in case of secondaries.
Yes, you are right. Maybe you can miss in the CT scan, okay? In MRI, you will see a small lesion you can miss in CT scan. So solitary lesion with much more edema, than you see the tumor is very small and looks proportionately small, and the edema is much more there, okay? It could be metastasis, just from the CT scan, just from the look. Okay, so these are all differential diagnosis.
Metastasis also, doctor, it has got a tendency to affect the gray-white junction. Why? Prakash, Dr. Prakash?
Yes, sir. Metastasis. So,
because that particular place suddenly blood vessels becomes narrowed down. So the two muscles, they travel suddenly, there is a blockage of the journey or the travel of the two muscles. So there's a predilection of gray-white junctions. And what is the common tumor which gives rise to metastasis?
some lung cancer, lung carcinoma, sir.
Yeah, lung cancer, but melanoma is one of the common tumors which can metastasize to the brain.
To the brain.
In males, it could be prostate, women breast. Yeah, correct.
Okay. Now we are confused with whether the picture, is not clear. So maybe meningioma, maybe metastasis, maybe tuberculoma. Okay. So what else you like to do now?
So we can.
Was there any fever? Was there any fever, doctor?
No, sir. There was no history of fever.
Generally, infectious causes, they produce fever. Always you have to look out for fever.
Yes. Yes, no history of fever. So next, this scan shows the MRI of the brain. This is T1 weight image. Here again, we can see the I saw this is here you can see the mass in the right side of the brain, and the other slide shows this is the again after the contrast gadolinium, and this is again enhanced mass. After the administration of the contrast.
Do you have other views? The sagittal?
Yes, sir.
Contrast.
So this one is the sagittal view, and also the coronal view, and the other one is the flare image, where you can see the edema.
Mm-hmm. So what is the typical sign, just go back to the MRI, I'm looking for what, no, you don't have the contrast or sagittal. So what is the features of, what do you think this is?
So this looks like some meningioma to me, sir. So because
Typical radiological features of meningioma.
so there should be dual tail sign, and it is enhanced, contrast enhanced mass.
Okay.
And it is homogeneously enhanced.
Mm-hmm.
There can be some calcification can be there.
Mm-hmm. Sometimes you see a dual tail sign, there is a dual.
Yes, sir, dual.
That you see, no, in the MRI, go to MRI. Maybe in the sagittal, you have, this is not the contrast, in contrast enhancement, in the contrast view, this is a T2 weighted image, I think, in the this sagittal and the coronal. Otherwise, in the contrast, if you see the sagittal, in those, in case of meningioma, you see a typical dural enhancement. Okay, anyway.
So again, we can, this is arteriography and MRI venography can be done in this case. So this is basically done to see the vascularization of the tumor, and also to plan for surgery, because usually when the tumor is more vascularized, we can go for embolization before proceeding to surgery. So this helps in the management of the meningioma. And in case of meningioma, there is comes early and stays late features is seen.
Okay, so basically we go to the MRI. Okay, the contrast view, the previous slide. Okay. Basically, this you see, it's a well circumscribed tumor, with much edema. Okay.
Yes, sir.
Tumor is more in the sagittal plane. Okay, it's attached near this sagittal plane. This the midline. Okay, so it's encroaching. Yes. It seems like it's a. So you don't know whether it says it's a seems like a extraaxial tumor. You know what is extraaxial?
Yes, the extraaxial that is outside the brain's.
So it's not
tissue.
coming from the brain per se.
Yes.
It's coming from the outside. So something coming outside from the meninges or outside and encroaching on the brain. Okay.
Encroaching. Yes, sir.
So for that you have to look at the T2 images. Okay. Sometimes you see this CSF rim, white rim around the tumor. Okay. Anyway, it looks like meningioma. You are right. So, and this MRI venography is done to see whether it is the tumor is in the venous sinus or not, sagittal.
It's involving the venous. Yes.
Yeah, in this case, it's not encroaching the venous sinus, so there is no filling defect in the sagittal sinus.
Sagittal sinus.
Okay.
So with all this history and examination and the investigations, my final diagnosis would be right parasagittal meningioma.
Okay. In the frontal, okay, in the frontal.
Yes, in the frontal.
Any comments, sir?
Okay, there's a lot of edema. We give steroids for edema, but amongst the steroids, only dexamethasone is preferred. Why not other steroids? Why is dexamethasone preferred over other steroids for treatment of?
So dexamethasone can again cause the So dexamethasone has a minimal mineralocorticoid effect and has high potency than the rest
Very
of the steroids.
Good. You are treating edema, so you want to give a steroid which has got less mineralocorticoid activity. Otherwise, in fact, you may worsen it. Dexamethasone is the preferred steroid. Good.
So, what to do?
Sir?
Now you have a patient with this meningioma. What to do now?
So, as the patient is symptomatic and there is seizures and there is weakness, and the patient is having headache and there is features of raised ICP, so I think the treatment of choice in this case is surgery. Definitive treatment is surgery in this case, and so we go for excision of the mass.
Prakash, can you go to the MRI image again?
Yes, sir.
The previous one, okay. Now you see, this tumor is more on the parasagittal region in the right side, okay? So frontal lobe is near there. So this tumor is causing the compression of the frontal cortex, okay?
Frontal cortex.
The motor area. So that's why it's causing some weakness on the left side, okay?
Weakness.
Now you should now correlate, okay? Why it is causing so many symptoms like, and why patient is having headache and vomiting? Number one is stretching the dura, okay?
Dura, yes, sir.
Next is, you see a lot of edema. There is brain edema.
Yes, sir. Brain edema. Mass effect is there.
There's a lot of brain edema, you see. Somehow there is a mass effect. There's some midline shift, you see. You cannot see the ipsilateral ventricles here.
Ventricle, yes, sir. Lateral ventricle is.
So you see it's pushed to the opposite side.
Towards the, yes, sir.
Yeah, so somehow there is a mass effect. So these are causing the headache, vomiting, okay? And why weakness? Again, due to this compression of the motor area in this frontal lobe, okay? And seizure, of course, like Sir has said, any frontal lobe, any cortical lesion, it will cause seizure.
Seizure.
Explain the symptoms.
What is the anti-epileptic drug which is given for seizures, Dr. Prakash?
So these days, the most preferred is the levetiracetam, sir. Levetiracetam.
Very good. Initially, we were giving phenytoin, but what happens is that when you give phenytoin or carbamazepine or phenobarbital, they are hepatic enzyme inducing drugs. So they interfere with other drugs, the steroids or the chemotherapeutic agents which you are planning to give. Whereas the sodium valproate is a hepatic enzyme inhibiting drug that also can interfere with other drugs, steroids or chemotherapeutic agents. Levetiracetam is a wonderful drug because it neither induces hepatic enzymes, nor inhibits hepatic enzymes, nor gets metabolized by the liver. So it's a wonderful drug with no drug-drug interactions, very safe, especially in elderly patients with seizures who have a lot of comorbid conditions and are on multiple drugs. Levetiracetam is very safe because its safety profile, not much drug-drug interactions. So, and these tumors, most of these tumors are found in elderly age group, with seizures. So levetiracetam is a wonderful drug with a very good safety profile with practically no drug-drug interactions. So levetiracetam has scored over other anti-epileptic drugs which were conventionally used like phenytoin.
Yes.
So you have taken history examination, you have done the diagnosis, and surgery was done. Okay.
Yes,
So,
sir.
any more thing you want to add, Dr.
I think he has done well, sir, and you have also covered most of the
Yeah.
points.
So, yeah, history examination was covered nicely. So, our so what I think is that in any neurology, neurosurgical cases, main is the history and examination. So you don't miss the lesion, because ultimately we do CT MRI to localize the lesion for diagnosis, but for practical purpose, you should know how to take the history properly. Our main aim is
Yes.
diagnosis. So to look
Diagnosis. Yes, sir.
yeah. So for that, you have to take a proper history, detailed history, okay, systematic history, okay, focus history,
Yes, sir.
so that you can localize the site of the lesion. So in diagnosis, you have to first do the localization. What is the site of lesion? Then you go for what type of lesion it is, whether it is whatever, what the nature of the lesion. Okay. For that, you have to do again, take an examination so that you know whether it is congenital lesion, whether it is acquired lesion, inacquired also, whether it is neoplastic lesion, whether it is infected lesion, degenerative lesion, whether
Yes,
it's
sir.
traumatic, vascular. Okay. So every lesion, every
Yes,
pathology has typical features, typical presentation. So you should know that. And you should examine each and every uh, components, okay, of CNS so that you can localize, because sometimes we don't know where is the lesion coming from, what type of lesion it is. Okay.
yeah. Yes, sir.
Proper anatomical, physiological knowledge, okay, then you can focus on the history and come to the conclusion, okay. Then we have to, if you
Yes.
are confused, we have to do the CT, MRI, and from that final diagnosis is done, and there are various armamentarium, various tests that are available from which we can localize the lesion. And the last thing I want to say that, after we don't know, maybe radiological, sometimes it's confusing, So the histopathology diagnosis is the ultimate test, okay? Some histopathology, then the diagnosis is done, okay? Whether it is meningioma, glioma, whatever type of tumor it is, sometimes they have different radiological pictures, confusing radiological pictures. So your histopathological diagnosis is the last resort, From that, you can now say that it is which type of tumor. Okay.
Yes, sir.
Anything, sir? Any concluding your?
I think, you have done, you have given a good history examination. As Sir rightly said, history is very, very important, especially in neurology. In fact, there have been good neurophysicians and neurosurgeons of yesteryears when there wasn't much imaging like CT and MRI. With history and examination, they could even pinpoint the lesion. So history and examination are very, very important, especially in neurology and neurosurgery.
Yes, sir.
Okay, thank you very much, sir. And thank you, White Army, for providing us this platform. I would like to share more in the future. And I think we should continue this in the future, I think. And it was nice meeting. We will continue. I've been acquainted with Professor Sreenivas also. It was nice sharing a platform with you. Thank you very much.
Thank you, sir. I also thank Rajkumar sir and White Army for giving me such an excellent opportunity. Thank you. It was a wonderful evening.
Yeah, sir. Thank you so much, both of you. And to conclude, actually, it was indeed a mind-blowing session. Definitely, everyone will agree to this, sir. And it was actually very interesting to see how the case was dissected and discussed. So thank you so much to our mentors of the day, Dr. Sreenivas sir and Dr. Rajkumar sir for teaching us. And we need your support and guidance throughout our journey, sir. So thank you. And it was actually a great effort by our presenter, Dr. Prakash, who could, so that we could actually learn a lot because of your well-prepared presentation. So thank you, doctor. And yeah, and we, the White Army, are very happy to join hands with Grey Medicos of Nepal, and we'll take this a long way. At last, I want to thank all the viewers who have joined us via Zoom and YouTube, and they were actually also enthusiastically answering the chat box. Yeah, and thank you all for joining this session. Have a nice day.
Thank you.
Thank you.